Hi, everyone, and welcome to Wellness Curated by Anshu Bahanda. Today, we're going to talk about ethical dilemmas in aesthetic surgery. Now, this subject is very topical, and it's in the news at the moment for two special reasons. One being, never before in my lifetime, I think, is it so important that we accept our bodies and we're happy with our bodies because of the internet. I think it's our responsibility as a generation to make sure that our children understand what beauty is. And people are seeing shocked images on the internet. And, I'm trying to encourage people to embrace their individuality. What really is beauty? And Khalil Gibran said it really well. He said, beauty is eternity, gazing at itself in the mirror. But you are eternity and you are the mirror. Isn't that beautiful? And the second reason is that it's a time when people are running to their local beauty parlors and getting fillers done, and sometimes more than that. And a lot of people don't know what qualifications are required to have anything done to yourself. And that brings me nicely to our guest today, who's very qualified to answer all our questions. Today, we have Dr. Ragoowansi. He's a consultant plastic and aesthetic surgeon. He has been with the NHS for 19 years. He works at a private practice as well. He's a senior consultant at Barts Hospital. He's a full member of the British Association of Plastic, Reconstructive and Aesthetic Surgeons, or BAPRAS. He does reconstructive surgery. He specializes in areas like body contouring, chest wall reconstruction. He does management of problem scars and lots of other things. So welcome to our chat, Dr. Ragoowansi.
Thank you, Anshu.
So I'm going to jump right into the questions and ask you, in today's day and age, when fillers and Botox are so common, what is considered to be plastic surgery? What is aesthetic surgery? And what is the difference between that and getting Botox and fillers?
Thank you, Anshu, for that kind introduction. This is important to differentiate because plastic surgery is from the Greek word plastikos, meaning to mold or to reconstruct or to make. And that essentially refers to reconstructive surgery, be it of the chest, be it of the face, be it of the upper and lower limbs. So I, for example, on the reconstruction side, do upper limb work on the nerves, I do facial reconstruction, and I also do breast reconstruction. That's done under the microscope, and that essentially is reconstruction to restore form and function, as opposed to aesthetic surgery, which is synonymous with cosmetic surgery, and that essentially is beautification. And in other words, anti-aging. So, of course, with other elements of nature, we age. As we age, skin droops, and that's from head to toe. And essentially, aesthetic or cosmetic surgery is there to be able to restore that youthfulness, take away the excess skin, and to suspend the deeper tissues to recreate the look that we were when we were in our 20s and 30s. So aesthetic surgery and cosmetic surgery are synonymous. And as you say, it is very, very popular. I'm just going to give you some figures in 2019 of what kind of numbers we're looking at as far as aesthetic surgery in this country is concerned. So here goes. The UK's most popular plastic surgery procedures in 2019, just before the pandemic. In women, breast enlargement, 7,500 cases. Breast enlargement done in 2019. Second most frequent, breast reduction, 4,000. The third, blepharoplasty, which is eyelid tuck, upper and lower lid, and that's 2,800. Abdominoplasty, tummy tuck, and that's 2,750. And liposculpture, which is 2,300. These are the number of cases done per year in the UK in women in 2019. In men, very interesting, Anshu, very interesting. In men, can you guess what the top procedure is in men?
Something to do with the V shape?
It's the nose. It's the rhinoplasty.
Wow. Oh, wow.
Yeah. So 570 cases of rhinoplasty in 2019 in men. And the second most common, this is incredible, is ear pinning back. Lots of us are born, lots of us are born with the ears pointing forward, like an elf. And lots of people tend to live with it. They get teased as they grow up in adolescence, but they then get used to it, they gain their confidence, and they leave it alone. But quite a few have problems in adolescence, in childhood, and then later on in life, when they, for example, get divorced and meet another partner, they change a job, and it becomes a focus for feeling nervous, losing self-esteem, losing confidence. So men, more than women, are more conscious of this particular anomaly. So 400 cases of ear pinning back done in 2019. The third one, again, is eyelid tuck, which is 330 cases. Breast reduction, quite a few of those are done in men.
Wow.
And this is the term called gynecomastia, which is male breasts or man boobs. Right. And I, for one, also do quite a lot of, in my practice, 90%, 92% are women, 8% are men, of which the majority are man boobs. They come for man boobs and gynecomastia reduction when a man develops fullness of the chest, and some occasions it's mild to moderate, but I see the most severe cases where literally they have a B or a C cup breast size in men.
Wow.
And the last procedure in men is liposuction, which again is lipo contouring to retain shape and the V shape that you're talking about.
Yeah.
So you can see how popular these cases were. Of course, during the pandemic, there was a dip because people like me who were working in the NHS, we went straight back to the NHS. We closed our private practices down, and essentially no cosmetic surgery was done for a good 1 year to 18 months.
Wow. So you make people look beautiful, basically, and also help them have, a great quality of life when they've had medical conditions.
Yeah, so it's essentially a very fulfilling role and that's why I do reconstruction and cosmetic. I don't just like doing cosmetic, and I don't just like doing reconstruction. And I have a healthy mix in my practice, a healthy marriage of the two specialties. And of course, there's an overlap because when you reconstruct a breast, for example, after breast cancer, you're restoring function, but you're restoring form as well.
Yes.
So there is it's like a Venn diagram. There's cosmetic, i.e. and aesthetic, and there's reconstruction. And there is quite a big overlap in between as well.
Okay. So then tell me, in terms of what you do so how much of it is cosmetic? How much of it is reconstruction? And what is non-medical? So I'm intrigued about this whole Botox and filler thing as well, because we get a lot of questions about that.
Okay, well, let me elaborate then. So essentially, there's surgical and non-surgical.
Right.
Okay? Non-surgical is where the Botox, filler, chemical peel, laser comes into practice. So essentially, as the term says, it's non-surgical. So if you look at Botox, for example, that's injection of a toxin into the muscle to relax the muscles and therefore help reduce wrinkles.
Okay.
Filler is a substance, usually hyaluronic acid, which is injected under the skin to restore volume. And as one ages, you lose volume and the tissues descend, especially in the face. Okay. For example, the fold between the upper lip and cheek, the nasolabial fold, gets deeper and gets laxer as you age. So what a filler does is restores that.
This one, okay.
Yeah, exactly, yeah. And that applies to lips, applies to marionettes, applies to the neck, applies to the ear trough, which are the small little dips that you get inside the lower lid, which occur when you age, because the fatty tissue that gives you that youthfulness perishes as one ages.
Okay.
So that's filler.
Okay.
Then of course, there's ancillary procedures such as laser, which are and lasers. I mean, I can talk to you all day about lasers, but essentially lasers are used to tighten the skin. Lasers are used to rejuvenate the skin.
Okay.
And then you've got chemical peels, which are essentially agents which are useful in breaking down the top dead layer of skin, in refreshing the pores, in providing you with a uniform tone to your face and your forehead. So that's a chemical peel. And these are all non-surgical procedures, and they're actually much more popular than surgical. Now, of course, because I'm a surgeon primarily, I don't have those figures to hand, but I can tell you the non-surgical procedures are done far greater than surgical ones. And in fact, you may have looked at the papers yesterday. A couple of MPs have lobbied that we should now have a regulation or a form of jurisdiction as to who can perform fillers out in the wide world. Because I'm afraid that industry is not regulated. And I, for one, wrong places, wrong patients, wrong environment, and then they land at our doorsteps with problems such as infection or lumpiness and so on.
So tell me, if they go somewhere and get something done and they come to your doorstep, do you have to entertain them? Do you have to look after them even though they've gone elsewhere and got something done that might be unqualified and not okay?
Look, I'm a doctor first and then a plastic surgeon. So at the end of the day, a patient is a patient. And my colleagues will all agree with me that whenever a patient comes to our door, the first thing we do is make sure that they're comfortable and we look after them. It doesn't matter where they've been to. We go through the history, we examine them, look at the problem, and try to solve it for them. Yes, there are a lot of patients now going abroad for medical tourism, having plastic surgery done elsewhere, Turkey, Malta, Poland, and then they come back to our doorstep with problems because the follow-up here isn't as good as it should be. But again, patient is a patient. We as doctors are individuals who look at facts, who assess the patient and treat them based on clinical findings. So we don't tend to be we don't tend to judge, we don't tend to be biased. We just look at the patient, look at the problem, and solve it.
That's amazing, actually. And that's when you realize what amazing work is done in the NHS in our country, actually. It's creditable. Because, you always see newspaper reports saying this is not enough and that is not enough. But clearly, the reason things aren't enough is because you're picking up the pieces of not just what's happening in the country, but even outside.
Well, yeah, I mean, there are huge numbers of patients now coming through with problems after medical tourism who the NHS is treating, and of course, NHS is free at the point of need.
Yeah, incredible. So tell me, in terms of dilemma, I'm sure there are times when you need to turn people away because your profession is such. So when and why do you turn people away when you say, don't get this done?
This is a really nice, interesting question, Anshu. And actually, this is where ethics come into the equation. Because technically, a senior person like me can do virtually everything. Right. But now, in the latter years of my career, I'm learning to say no more and more. Because I have seen what can be done. I've seen the problems that can occur if the wrong patient is operated upon and the wrong technique is used. So to answer your question, I think it's probably easier to divide it up into patient factors and anatomical factors. So my reasons for saying no to a patient, as far as patient factors are concerned, are number one, if I don't see eye to eye with a patient. They walk in, they sit next to me or opposite me, and if I just feel there's no rapport, there's no eye contact, I don't feel comfortable with them, that's a red flag straight away, number one. Number two, those patients who've been to lots of other surgeons. Now, I'm in central London, in Marylebone, and we all know each other. We're all friends, and we've been, together for many, many years, my colleagues. So we pick up the phone, and we talk. And if I see that a patient's been to Mr. X, Mr. Y, Mr. Z, and then come to Ragoowansi, there's an issue there. Okay?
Okay.
Number 3, if the patient has had lots of previous surgery, that's a red flag, because that indicates to me that they've almost become addicted. And that then leads me on to the diagnosis, possibly, of body dysmorphophobia, which is actually more common than you think. And essentially, it's a condition where the patient looks in the mirror and sees something that we just cannot see. They may be beautiful, they may have a great pair of breasts, they may have a great figure, but actually, to them, they look ugly.
Wow.
They may have a great pair of legs, they may look wonderful, but in their eye, no, I'm not happy with my legs. Those patients where what they can see, I can't see, is a problem. Another red flag.
Okay.
And finally, those patients where you really are not able to meet their expectations. They sit with me, they start chatting with me, and the first thing they do is they're on the phone showing me pictures. Oh, Mr. Ragoowansi, I want to look like this. I want to look like this. I want my breast to look like this. I want my waist to look like this. I want my nose to look like this. Whenever you have that kind of patient, especially after you've examined them, and you know that that is not achievable, that is again a red flag. So the last point I would summarize by saying is, if the expectation gap is wide with what they aspirate to and with what I can deliver, there's a wide gap, I say no.
Okay. Okay. And so that was the patient factors.
Yes, yes.
Then you were talking about something else. Was that medical factors, the second thing?
Yeah, so now these are patient factors. And to be honest, those are intangible. Those 6 factors come with experience. They're not in any book. They just come with experience. And people, consultants like me who are senior enough now to be teaching this to the junior generation, this is what we teach, because it's not in the books. So something you pick up from experience. Okay. As far as the anatomical factors are concerned, it's, for example, a patient may have a good pair of breasts, C or D cup, commensurate with the rest of the physique, and they want to be larger. And you cannot fathom, why is it that they want to be larger? So breast size, for me, is very important. And equally, if patients are of a reasonable cup size and they want to be smaller. Now, of course, there are functional reasons why you reduce the breasts. But if I can't quite fathom that in talking to them, that's again a red flag to say that, look, what you're asking for here is unreasonable. It's not required. That's the first thing. Secondly, young patients. Those patients in their late teens, early 20s, I'm very cautious about, because I'm a father, and it's important that we have a moral compass that we operate within. We should not be saying yes to patients straight away, especially those who are young, who may have been influenced by social media, by friends, by teasing, or just by the wide exposure to the world suddenly. Those patients need to be carefully counseled. And a lot of the time when these young patients come, I do say to them, I want to see your mom with you. I want to see your father with you. So, for example, I saw a patient the other day who is 18 years old and is requesting a breast reduction, and she is a 32K cup size.
Wow.
K cup size.
Yeah.
And in my 30-year career, I've only seen that twice, and that was the third time.
Okay. Right.
So now the problem here is that she is completely convinced that she wants the breast reduction done, and I can see why. She can't play tennis, she can't go swimming, she can't wear nice tops. She's uncomfortable going on holiday. She always wears baggy clothes, baggy jumpers. I can see that. But also at the age of 18, you cannot imagine what experiences you're going to go through in your second and third decade. So, for example, a breast reduction involves scars. And even though my scarring is very fine, scar is a scar. And when looked closely, the scar is always visible. And that scar stays for life, number one. Number two, if you reduce the breasts, there's a small. I do tend to preserve the nerve supply of the nipple, but there's a small chance that after breast reduction, you may not have sensation, and you may not be able to breastfeed. Now, breastfeeding is very important for maternal bonding, but also for nutrition for the baby. So these are all factors I have to look at. So again, I haven't said no to her. I said to her, these are the facts. I want you to convince me that this is what you want done. Having read my letter and understood that there are certain things which I cannot change, like scarring.
Okay. So interesting. Wow. And so that made me think, when you talk about young people and making them think twice about, saying come back with a parent or give it a real serious thought, you must have also have you worked on sort of gender transformations as well?
I have, but not transformation per se. I don't do the genital surgery, but I do breasts. So I do for a man to a woman, once they've had everything else done, and the only thing left is to give them a decent chest dimension. I then do a breast augmentation with or without uplift. Or if a woman goes to a man, then obviously a breast reduction. But that's the only kind of arena that I cover as far as transgenders. And it's rare. I think I do maybe about 1 or 2 cases a year.
Okay. And tell us a little bit about the latest developments in this field, because things are moving at such a fast pace, right?
Yeah, that's true. I mean, I have to say that my specialty is one which is why I enjoy it, which is why it's my passion and I love it, because it's a beautiful marriage between art and science. Because there are parameters that one has to be within in terms of reconstruction or cosmetic, but a lot of it is the third eye, is that perception, it's that fourth space that you have to imagine what you want to achieve from a patient and what shape you want to achieve from what they are now. So to answer your question, it is one of the few specialties where there's nothing new majorly. Yes, there's tissue engineering to produce new skin. Yes, there are certain types of fillers which are new, which are longer lasting, for example. Yes, there are certain instruments that we use to make access easier and to make the scar shorter, for example, in the breast. Breast implants have evolved considerably in the last 5 years, and the implants we use now are nano-textured, so they don't cause a capsule, but also they prevent the risk of lymphoma. So there are small little steps as far as innovation is concerned. And yes, in the lab, there are things like tissue engineering, 3D printing for new skin, 3D printing for producing ear cartilage for those babies who have deficient or small ears. There are certain things like that. But actually, in the main issue, in the clinical arena, nothing much has changed. Because it's a specialty which is mainly your hand-eye coordination and your clinical skills and your hands. It's a very manual specialty. Basic skills that to be able to, you have to have that third eye, the imagination. It is an art to rebuild a part or the whole body. And of course, there are certain small innovations that are coming through, but in the main, it is a very manual specialty, and which is why I don't think we will have robotic surgery in my field for a very long time to come.
Interesting.
Robotic surgery has entered the arena of general surgery, orthopedics, ENT, but I don't think my particular specialty, be it reconstruction, be it cosmetic, I don't think that robotic surgery is imminent. Purely because you cannot account for the fact that you need that human touch. You need that ability to be able to make decisions as you advance in your surgical planning, and also to have that third eye to be able to imagine what you want to create. I don't think, correct me wrong, but I don't think yet we have software that's sophisticated to emulate that kind of cortical thinking that we do as plastic surgeons.
Right. So say someone comes to you for breast reconstruction or eye reconstruction or, cosmetic or reconstructive surgery. Won't the computer be able to give them lots of options and they pick one? Or is it still a lot? Is it still fairly manual?
There are simulation software programs whereby you essentially scan your face together with the abnormality, and then the software morphs you into what you could be.
Okay.
And yes, I do use it in my practice to a certain degree when I'm measuring breasts, when I'm using a template to assess what kind of breast shape I'm going to create, for example, in a mastopexy or an uplift. But to be honest, as I get more senior, I don't like to use those devices because they give the patients a false sense of security, and they give the patient some kind of image that they will be. Now, nothing is will in medicine or surgery. Nothing is for certain in medicine or surgery. And I think it almost gives the patient a certain benchmark, which, if achieved, fantastic. But if it doesn't, then it becomes a source of disappointment for the patient. What I like to do instead is to show my huge gallery of pictures on the internet, on Instagram, to then show the patients, look, this is what I have done in the past in patients of your ilk, of your physique, of your cup size. And these are the results I have achieved in my career. And I think that's a more earnest, it's a more honest way of approaching the problem, and be able to tell the patient, listen, I can't guarantee you anything, but if you look at my track record, this is what I can produce. And equally, I say to them, these are patients I'm proud of. And there are some patients where this has happened. So, for example, I do a lot of Asian patients in terms of breasts work, or eyelids, for example, in Asians. And you and I are both Asians, and we know that we can pigment. Our scars can pigment. So the first thing I'd say to any Asian is, please, please, please remember, I will tuck the scar beautifully. It'll be a thin scar. There's a small chance the scar may pigment. And here is an example, so that they are aware that, you know what, there's a good chance, 90%, 95% things are going to be fine. There's a small chance that even though Raj Ragoowansi hides and tucks the scar may pigment and therefore be visible.
Okay. When should they think about reconstructive surgery, and when should they think about aesthetic surgery? When would you recommend to a patient that, okay, go get it done? You need it now. They're obviously different things, right? Both of them.
Yeah, absolutely. So let me qualify that. So reconstruction surgery is essentially surgery to restore form and function. So for example, you've had a breast cancer, you've had a mastectomy, had your radiotherapy and chemotherapy, and you now want to be equalized as far as breasts are concerned. Similarly, if you've had trauma, if you've had an accident and you've injured your nerves in your wrist, for example, a glass cut to the wrist can be devastating, and essentially you lose the nerve of your hand, and therefore you can't feel. You lose a nerve of your hand, i.e. the ulnar nerve, and you can't move your fingers in a fine fashion. Now, those kind of things are functional reasons to have surgery done, and there's no real time frame that I can give you for that. That is the patient deciding that it's time they have better function, a better quality of life. As far as cosmetic is concerned, there is actually no such age. There is all these myths coming from America that, yes, have it done before you age, or have it done at an early age, so you prevent aging or you slow aging. I have to say, I don't believe in that. I think you have to be very circumspect, have to be very careful and measured, and seek advice, read the literature, take what you see on the internet with a pinch of salt, and go and see people who are sensible senior people for advice before you do anything as far as cosmetic is concerned. Because although you feel you may want to have it done, as I said to you earlier, it may be that someone examining you may say, well, actually, you don't need it. Or equally, they may say, yes, you do need it, in which case, obviously, you think about it. But it is important that you see a consultant plastic surgeon who has followed the guidelines of our BAAPS, which is the British Association of Aesthetic Plastic Surgeons. And essentially, we as a fraternity see the patient. We don't tend to advertise our services. We see the patient, we give them an earnest consultation, we send them a letter of consult, we give them a cool-off period, very, very important, to leave the patient alone for a good 3 or 4 weeks. Let them think about it. Let them dwell on it. Let them sleep on it. And I always, like my colleagues, always offer a second consultation. Because the first consult, it can be an hour long, an hour and a half long. It's never quite enough. Because aesthetic surgery is personal surgery. And you need to, I say to my trainees, get under the skin of your patient. Learn to understand them. Learn to know what their aspirations are. Learn about their fears, about their goals, about why they've come to see you now. What's the reason? Are they looking for a new job? Have they met a new partner? Do they want a better quality of life? So that conversation, the first time you meet them, may be slightly stuttered, maybe slightly impersonal. And therefore, it's very important that you see the patients twice. And sometimes I see my patient 3 or 4 times before I convert to surgery.
So you've told us something very important. You've talked about BAAPS, British Association of Aesthetic Plastic Surgeons, where you look when you're trying to find your plastic surgeon. Don't just go by word of mouth, correct? Just make sure that they're under this association.
You know, when I meet at parties or you know, outdoors and so on, they ask me this question time and time again: how do I choose a plastic surgeon? And again, it is not something that I can give you 1, 2, 3 about. But what I can tell you is a few tenets, which is, do look them up and research them. Number 2, make sure that they have had or are in an established NHS practice. I think that's very important, because in the NHS, we have full appraisals yearly, we are measured, we do monthly audits, we are scrutinized. We are actually scrutinized. And our results are scrutinized, our methods are scrutinized, our consent forms are looked at, our processes are all regulated. And it's very, very important that if you are undergoing aesthetic surgery, if you can choose someone who either has been in the NHS for a long time and then retired from the NHS, or someone who's currently in the NHS. I think secondly, please don't be dazzled by great clinics and plush receptions and huge websites and, you know, Instagram 50,000 followers. Because actually, I'll tell you, it's those who've got millions of followers, those are the ones who need those followers to get the work in, if you know what I mean.
Yeah.
So don't be dazzled by that. And I think, I'm afraid, in our world of social media, there's a lot of that going on where, you know, you go on the internet and you see a great website, and you go on Instagram and that person's got, you know, 1 million followers, and straight away you think, well, hang on, you know what, that guy's good. But actually, you know what?
Yeah.
That's not true. That's actually not true. And the other thing to say to you is that do make sure that they show you their own gallery of pre and post pictures, not Photoshop. Again, this was in the news yesterday. A couple of MPs are lobbying that patients are put on the internet with the post-op pictures being photoshopped, and therefore giving potential patients an unrealistic expectation and unrealistic goals which they may not be able to aspire to. So please make sure that you sit down with that consultant and they need to show you their own pictures, not modified, raw pictures of pre and post, and not just the good results, but also the average and the slightly poor results.
Okay. Interesting. So you actually show people where you feel like it didn't work out right.
Yeah, I do. Yeah. I show them that, look, the scar is slightly uneven here, the scar may be pigmented here. Despite me trying my utmost, there's a slight asymmetry as far as the nipple is concerned, because it's not an exact science. Surgery is not an exact science. And we, as surgeons, especially plastic surgeons, we plan and we plan. I plan right from the time the patient converts to surgery to them being on the table. I've already thought the patients through 6 or 7 times, especially the morning of surgery. I get up early in the morning, I sit with their picture and I study them and I make a plan. On table, I measure, like my colleagues do, we measure everything. We maintain symmetry, we establish symmetry, but the tissues as they're left on the table may not be in the same place 6 months on, because nature is very difficult to predict. It's very
Absolutely.
difficult to
Yes.
be able to predict exactly what's going to happen because body tissues are different even within the same territory. So, for example, facial skin heals differently to eyelid skin. The neck heals very different to the breasts. The breast heals very different to the tummy. So even within territories, there are regional differences. And therefore, it's very difficult to predict. Yes, it's very important that the patient is informed and nothing is a guarantee. And all this counseling is under the umbrella term of informed consent. And it's very important that when a patient decides to have surgery, that on the day of surgery or before, preferably, the patient is given a consent form with all these risk factors within it. And the patient has had time to digest them, think about them, ask questions, and then sign the dotted line. And informed consent itself is a talk I can give you another day. It's a very, very important process that we as surgeons follow. But again, it's part of the guideline of our BAPS and BAPRAS protocol, which we follow as members.
So just to reiterate, what I would love you to do is talk us through all the steps that a patient should go through up to surgery. So there'll be steps they need to do before coming to a plastic surgeon, and then there'll be things they need to do up to surgery. Will you just quickly talk us through these steps?
Okay. Well, perhaps I'll be slightly selfish and just go through breasts because that's what I do the most of.
Oh, sure. Anything's fine. Yes.
Let's say there's a patient who has had 2 or 3 children, breastfed, and now is looking to rejuvenate the breasts. From a cup size point of view, from the nipple position point of view, and general laxity point of view. The first thing that needs to be done is a thorough research of what they're after. And the internet is good for that. I'm not, I was slightly damning of the internet earlier, but it has its advantages. I think it's important. In my day, it was called an Encyclopedia Britannica. It's now Google. That's fine. Do look at various pictures, look at various literature, and then start to look for the appropriate plastic surgeon for that procedure. And for that, I have to say our website, the British Association of Aesthetic Plastic Surgeons, the BAAPS, is a very good, informative website. From that website, try and identify 3 or 4 potential consultants you would like to be treated under. And then, of course, research them individually, like I discussed earlier, in terms of their track record, NHS status, in terms of their experience, and so on. Then try and talk to a friend who's had the procedure done, because then you get a very different sort of perspective on things in terms of what it was like being a patient under a particular surgeon. So I, for one, have a list of patients who are happy to talk to potential patients. So if a patient rings my practice and says, Raj did a mastopexy augmentation, which is an uplift and augmentation on a particular patient, and I'm thinking of having it done. I met him the other day. I'm happy to see him again. But I want to speak to a patient who's had it done before. And we have a list of patients who are kind enough to allow them to call them and speak to them and even meet them. Because it's very nice to get that first-hand knowledge from the patient who's had it done already.
Yes.
And of course, the assessment's important. After the assessment, then consultation letter, read through it carefully, understand it, make lots of notes, and then see the consultant again.
Okay.
Excuse me. Yeah.
Okay, so that very clearly you've outlined. Thank you for that, Dr. Ragoowansi. I think that's going to help a lot of people because you very clearly outlined the things that they need to do and the bodies that they need to be part of, which was that the whatever plastic surgeon or aesthetic surgeon they choose, they need to be part of either in the UK BAPS or BAPRAS. So that was very useful. Right. Before I move on to any questions from the audience, any last words of advice for people listening in?
Don't jump into any form of procedure without giving it some thought. This is not something
Without?
done on a whim, without thought.
Okay.
This is not done on a whim. These are very important, life-changing procedures. Sadly, the internet and social media trivializes some of it. Be very measured, give it some thought. Don't jump into having procedures done. Do your research and meet the appropriate consultant, the appropriate qualifications and experience and background.
Wonderful. What is the percentage of risks involved in both surgical and non-surgical procedures? And are these procedures reversible?
Okay, so on the non-surgical side, I mean, it's a very general question because obviously each particular procedure has their own risks and so on. But I think, see, for example, Botox, within 4 to 6 months, the effects are reversed. So obviously it dissolves, the nerves then start to work, and the muscle then fires, and the wrinkles then come back again. So as far as Botox is concerned, the risks are when it's injected in the wrong place, when it's injected in the wrong muscle, and the wrong dose. In those patients, you can get eyebrow asymmetry, upper lid that can drop, asymmetry of the forehead. And although it's a complication as such, which may be correctable by injecting the other side or equalizing it with some more Botox, which is done at 10 days, 2 weeks, if left alone, eventually that'll disappear and the whole area or cosmetic unit will normalize or equilibrate. Same with filler.
Okay.
You inject the filler, if it's too lumpy, if it's too much, you know that by 6 to 9 months at the most, the filler will resorb, the body will absorb it, and you'll be back to where you were. As far as surgery is concerned, complications can either be early, within 48 hours of surgery, or later on, which is 2 weeks thereafter. And the complications of surgery can be irreversible. For example, scarring. Scarring, you cannot reverse scarring. Yes, you can fade it. Yes, you can lighten it. And of course, if you've had good surgical closure of your wound and you've had good healing, then you'll heal in such a way you'll hardly see the scar. But if you have a scar is there for life. As far as surgical complications are concerned, there's of course the risk of delayed healing. And if the wound has delayed healing, the scar can stretch. As I mentioned earlier, you can get asymmetry, which may be noticeable, and also loss of sensation, which can be disconcerting, especially if it's the breasts or if it's the lower tummy, which can happen after a tummy tuck. Liposuction carries some complications, which is things like asymmetry, lumpiness, and also swelling that takes time to settle down. So every procedure, be it non-surgical, surgical, does have an element of risk. Now, as a percentage, I would say to you that 92 to 95% of patients in my practice walk away without any problem. 5 to 7% have niggling issues, and that's my own figures after
5 to 7%. Okay.
Yeah, that's my figures as far as surgery is concerned. Non-surgically, i.e., Botox and filler, the complications are probably in the same realm. I'd say probably 90% are completely fine, 10% have some niggling issues. But it's very important that the patient knows these potential complications before embarking on the procedure, be it non-surgical or surgical, and hence the informed consent process is a very important one.
Okay. And also, just one last question. Would surgical procedures harm the growing up process in youngsters?
Harm is probably too harsh a word. I think what happens is that if patients enter the arena of aesthetic surgery at a very early age, then we all know that these procedures are not lifelong. Within 10, 12, 14 years, aging, gravity, sunlight exposure, all these things lead to laxity. So you may have a great pair of breasts or a tummy after a tummy tuck or a breast uplift. But I know, and I tell my patients this, in about 7 to 10 years, whatever you say, whatever goes up has to come down. And you do get laxity, you do get slightly skin thinning and so on. and therefore you need to have those procedures done again, maybe twice or 3 times. If you're young, then it is twice or 3 times in your lifetime that you have the procedures done. Secondly, if you're young, let's say in your 20s, and you're sort of in the process of courting and meeting the other sex and be able to have a relationship, then those are very difficult years, both socially, psychologically, and so on. To have a burden of aesthetic surgery on top of that, I think it's actually sometimes overwhelming to a patient. So that's why with young patients, I normally say to them, listen, you're building your career, you're making relationships, wait a little bit. You don't jump into it, because there is time. Why don't you have a stable partner? Why don't you make sure you have a stable job? And then you are in yourself confident, and then you know exactly what you want. Because half the time I see young patients come through my door, they don't really know what they want. They've actually just seen something on the internet, or they've been influenced by Love Island or the Kardashians, and on a whim, they want to get something done. Or they've had a comment from a boyfriend that's upset them. I had one the other day, a patient, beautiful girl, met someone, she's in her mid-20s, met someone who just commented upon her breasts and mentioned the fact that the chest was in a straight line. And that just threw her. It just threw her. And literally, she came the next day to see me and said, Raj, I'm so
that's heartbreaking.
And I'm just so embarrassed now, and I want to get something done. Now, that's the kind of patient where I'm not going to jump in, because plastic surgery is not the only solution. One has to get your head around that. And it's very important as senior consultants that we teach this to our juniors and also practice this with our patients. You walk in through the door, you want a breast augmentation because your boyfriend yesterday said that I can draw a straight line from your nose to your tummy. It's just appalling that comment was made in the first place, but then to act upon it and appease it by giving them breast augmentation straight away, that is something that's unethical. And which is why it's important. I mean, which is why this is a very topical forum that you've created. And actually, this is the kind of thing we need to be discussing about, because it's all possible to do. So technically, I can do it, but ethically, I've got to step back a bit.
You don't want to. Absolutely.
This patient needs help. This patient needs help, and it's not just plastic surgery; it's also psychological and psychosocial.
Yes. Thank you so much for that chat, Dr. Ragoowansi, for being so open and honest. That's what was incredible about this chat. So thank you for that. And to everyone listening in, that was Dr. Ragoowansi. And this is Anshu Bahanda at Wellness Curated. Thank you for being here today.